Welcome, ladies and gentlemen, friends and colleagues from the IACAPAP community. Together with me today is Dr. Gabriel Carlson. I'm definitely very honored to have Gabrielle as one of our speakers at the virtual conference. Let me just dive in. Dr. Gabriel Carlson, so would you like to tell the audience a little bit about yourself?
I'm really honored to be part of this endeavor. As you know, at the moment, I'm president of the American Academy of Child and Adolescent Psychiatry. I will be in that position for the next year and a few months. I'm also professor of psychiatry and pediatrics at Stony Brook University, which is a medical school part of the state system of New York State. It's on Long Island. Long Island, where I am, is about 55 miles from New York City, so it's kind of suburban. I did my training at UCLA and Washington University and the National Institutes of Mental Health. And I got interested in bipolar disorder, actually, for reasons that I outlined in my plenary talk last year at IACAPAP when I was about to assume the presidency. I didn't know if you wanted to hear a little bit about that, but it's kind of germane to how I ended up doing what I'm doing for my ACAP presidential initiative.
Fantastic. Gabrielle, I know you as a very driven, dedicated person, and definitely a true professional. Could you tell us a little bit about how do you, get to where you are right now? What drives you? What is your passion?
Well, they're two different questions, how I got to where I am and what drives me. Seriously, don't you know sometimes that when you have a question, you're curious about answering. I've always loved mystery stories, okay? They're my favorite TV dramas and books to read and so forth. I like a mystery and I like to solve it. And so for me, research is kind of that. It's like you have a question and you're trying to solve a mystery. And for me, this started when I was basically doing my training, and I took care of a young man that I thought had mania, and my colleagues at the time thought had schizophrenia. And I needed to demonstrate to them that young people could have bipolar disorder. This young man was his late teens. He wasn't, 5 and he wasn't 40. But people at the time thought that young people who were really, really psychotic had to have schizophrenia. So in my endeavor to understand why people didn't want to believe that a young person could have mania, I decided to go into child psychiatry to learn more about development. And in the course of doing that, I guess two things happened. First of all, I think we demonstrated pretty well that young people can have manic depressive illness, at least adolescents can. And then we entered a whole new phase of trying to understand children who are really explosive and emotional and very labile. And at least in the United States, there developed two schools of thought. One was that this population of very volatile, impulsively aggressive children had a special form of manic depression or bipolar disorder, and other people who didn't think that. And so for the next, 20, 25 years, there was what I called the bipolar controversy, arguing about what these children have and do they have bipolar disorder. Bipolar disorder would have been such a nice answer for these children. It would have, and it did, it conveyed the seriousness of their problem. It conveyed the complexity of their difficulties. It conveyed the fact that their families were often riddled with lots of similar kinds of problems. And so it seemed like that itch was being scratched. But the thing was that those children do not grow up to become the kind of manic depressive people that many of us feel is manic depression. In addition to that, the convergence of the explosion of using psychotropic medication, especially atypical antipsychotic medication, but also mood stabilizers on children, it produced kind of a backlash. Children had lots of side effects. It didn't quite cure the problem. And as a result, at least again in the United States with DSM-5, there was a movement to say these children don't have bipolar disorder. They have something, but they don't have bipolar disorder. So they ended up getting another name, a name that was developed at NIMH by Ellen Liebenluft's group. She called it originally severe mood dysregulation, and it became disruptive mood dysregulation disorder. The point is, we're trying to find a label for a group of children who are, as I said, explosive, labile, young, and that we don't have good treatments for. And so your original question of how did I get interested in it and what drives me, I'd like to be able to help these children. These are really complicated, seriously troubled children. We see a lot of them in the States. Do you see them much in Singapore?
Yeah.
Are they an issue in Asian culture?
Well, I can only speak from my own clinical experience. I'm the head of the mood anxiety clinic in the local child guidance clinic. I do see a lot of teenagers and with major depressive disorders. Just only a handful of conversion to bipolar or eventually become bipolar disorders. But I get a sense that this mood problem is this dysregulation, emotional dysregulation. It's like on the spectrum. I do tend to see more younger children in elementary school. I just want to bring up two cases, two boys, similar to your case studies of Jared and Stuart. One was in elementary grade 2 and the other in grade 6. So, well, they don't have clinical depression, but they do get into this explosive episodes that are disproportionate to the triggers. And so this is when I was thinking, is this intermittent explosive disorder or a DMDD, which you just mentioned? But I was so curious whether could there be other underlying conditions that make them dysregulate. Because there are issues with the labels or diagnosis of DMDD, because very often parents do not report chronic irritability, in between episodes. They could be quite happy doing their own things and playing. It's only when certain things are said or
when you say
done.
no.
Yeah. So I was even thinking about, is it a kind of OCD? Because one of the boys was, in fact, both of them were very preoccupied about certain things have to be done in certain sequence, but yet they do not have a classical OCD picture. And I was also thinking about autism spectrum disorder because of the cognitive rigidity, and they were like so insistent and adamant that they need to have it that way. I sent them through a formal autism assessment, did an ADIR and ADOS. Only one of the two were tested positive for ASD. So I'm seeing these young kids, prepubertal children actually presenting with a fair bit of emotional dysregulation. And I wonder whether are they from the same brew of or is this a spectrum? So I'd like to have a take on it, Gabriel.
So that's what I'm going to be talking about. I think there's a consensus at this point that the behaviors are transdiagnostic. That's the term people use. I think our language has complicated things. For instance, irritability is the term that people use for that behavior. And yet irritability is a proneness to become angry. It isn't what you do when you get angry. And so for many of these children, yes, they do have what I call a short fuse, but what gets them into trouble is what they do when they get angry. If all you do when you get angry is curse or you know, stamp your foot or slam a door or something like that, then nobody will be that upset about you. But if you throw a chair at somebody, or if you grab a knife, or if you threaten to kill yourself, or you threaten to kill them, what you do when you have one of these outbursts is really what impairs the child. And so what I've really become interested in is understanding the phenomenology better from the ground up. And if you look at our profession, you realize that the best work has really come from ground up observations. People looking at it in an unbiased way to understand how things look and how they evolve. And at that point, you then maybe can begin to cut nature at its joints. But I think what we've done is we've kind of gone at it backwards. We've tried to apply the structure of diagnostic interviews onto a heterogeneous group of kids, and we haven't really made the kind of progress I think we need to make. So what got me interested in this was manic depressive illness and bipolar disorder, the young man that I called Stuart in the plenary talk that I gave last year. But who I've ended up really taking care of are children like Jared, who is not a bad kid at heart, but when he gets something happens to him that he doesn't like or he can't cope with it, he gets really upset. He gets upset for a long time. He does things that when he calms down, he wishes he hadn't done. And he does it in any number of different places. And so he's really significantly impaired. And I think we need to understand those kinds of children better. And that's what my presidential initiative is about. And that's going to be what I talk about when I give my talk for you guys.
Oh, wow, that's awesome, Gabrielle. I think it's so interesting, this topic particularly, and we definitely look forward to you when you deliver the keynote speech on that topic. And I think your work also links research to knowledge acquisition, and I think that's very important. Only through research we can then derive knowledge and new understanding of the conditions that we see right now. I'm quite sure in 5, 10, or even 20 years from now, we'll know far more about mood dysregulation.
The other piece that I'm kind of interested in, and you talked about it, I wonder if you notice any differences culturally or ethnically across the children you see with bipolar disorder.
So there's two sort of aspects, I think, of a condition. There's the pathological parts. They're the things that make the disease the disease. You know, if you have an upper respiratory tract infection, or if you have tuberculosis, or if you have appendicitis, or if you have schizophrenia, or whatever the condition you have, there are the things that you have that make you recognize it as a disease. But then there's the pathoplastic parts of it. They're the parts that make it your interaction with the disease. So not everybody with ADHD looks like every other person with ADHD. So there's that intersection. And I'm interested in that intersection. And that's one of the reasons why I think I asked, say, how do you see these children in your clinic? I have a good friend of mine who is from Beijing, and when I went to China with her a few years ago, they saw children like this, but they didn't see them with the magnitude that we see them in the States. And so you have to wonder how much of that is it cultural, or, are there things that we do to exacerbate it, or whatever? I don't know. I think that's a really important question. In terms of the actual manic depression, what I call manic depression, again, I think there are the core features of it that make you recognize that it's manic depression. but what you're obsessed with, what you're driven to do. What Stuart, for instance, I tell the story of Stuart because it was just such a great story. Stuart was manic. I mean, he was going to write the world's best novel. He wrote reams and reams of letters. I mean, and do you know what happened to Stuart? What happened to Stuart was when he got his mania under control and went off to college, fast forward 40 years, Stuart is a professor of English in a large, prestigious Midwestern college. So there's the thread of who the person is underlying what it is they have. And I think that's what makes it interesting.
That is exactly what I think is quite critical for you to also describe and discuss. Actually, what you were saying is exactly what I've been thinking. How disease, as you said, the pathology is manifested in such a different way in the illness, in the personal experience of the disease. Mm-hmm. And actually, there's a third element, how society sees it. The kind of role that society gives to the sickness. And I mean, I was listening to what Seha was talking about patients. I do have a patient, a number of patients where, we spend a lot of time wondering about the diagnosis, flitting between ADHD, oppositional defiant disorder, and then finally settling on a bipolar disorder picture because, and after many years, we have, because we were so resistant to the thought that this was a very serious mental illness that needed a long-term follow-up. And I have a number of patients because over the years, our patients grow up. They're now in their 20s and 30s, and you can see the trajectories and the continuities or discontinuities of their symptoms are quite interesting. So it's certainly an area that we don't really have enough information. One of the things we should be doing, of course, is studying large cohorts across different cultures and ethnic groups, which I think we don't have enough of, and that's always been a little bit of my wish for the future, that we could study large cohorts of individuals and populations and try and find ways of intervening. Now, another question here. With the problem with doctors and a medical model, of course, is doctors always must have a diagnosis and then use drugs, right? Or medications. What about psychosocial interventions and other ways of handling, particularly if there is a cultural or a slant to the manifestation?
If we look at my dysregulated children in the way that we're talking about, we have who they are, how they feel, what they do, and the context. All of those are important dimensions to treating the condition or understanding and treating the condition. So you can have a family that's fairly tolerant and doesn't exacerbate the child's issues when he starts to get agitated, and they step back and the child simmers down. It isn't such a big problem. That same child in a family where a parent is dysregulated, or where they're living in a neighborhood where the walls are paper thin, and if you raise your voice, somebody's going to call the police on you, you're going to have a very different set of responses in those kinds of circumstances. I think that another dimension that we have is, and I'm having a lot of trouble getting my colleagues to understand this or to buy into it. So we have children like Jared who have explosive outbursts. In my story about Jared, he didn't want to do math, and he, basically levels the classroom because he has such a terrible temper tantrum. We can say that Jared has a condition. Let's say, for instance, we decide he has ADHD. We can treat his ADHD, and treating his ADHD may make his symptoms somewhat better. He doesn't have as many explosions. They aren't as bad as they were. He gets accommodations in school. Parents, and teachers learn a little parent training. you're treating the condition. But if Jared has a meltdown, if he has one of his explosions, what do you do about that? Just saying he has ADHD doesn't do anything for that. Or just saying, whoa, he responded to methylphenidate. It doesn't do anything about that outburst. So the metaphor is kind of like seizures. If you've got somebody with epilepsy, there are probably things that you can do to keep that person from having seizures. Don't show them flickering lights, or, don't put them in a noisy room, and make sure their anticonvulsant levels are, where they need to be, and that they're on the right anticonvulsant for the kind of seizure disorder that they have. But if that person lays down on the floor and starts having a grand mal seizure, you don't say, oh, you meet criteria for a seizure disorder. You should respond to carbamazepine. You have to do something about the seizure, right? And so what you do you leave it alone? How long do you leave it alone for? When do you call an ambulance? Do you give the person an intravenous benzodiazepine? What do you do about the actual seizure? Is a whole different treatment situation than how you treat the condition, how you treat the child, and how you treat the environment. So there's a lot of balls you have to have in the air when you're dealing with these kinds of issues.
All right. Thank you very much.
Thank you for inviting me. I'm looking forward to attending the IACAPAP conference, and I really want each and every one of you to join me. Thank you so much.